Gives me great pleasure to introduce Dr. Jamie Duckers. Jamie is an adult CF physician and researcher in the CF Centre in Cardiff in Wales. He's done a phenomenal amount of work on cardiovascular disease in adults with cystic fibrosis, and also had a very keen exercise interest. So we'd like to listen to Jamie telling us about exercise for cardiovascular health in CF. Thanks very much again, Jamie, for agreeing to speak today.
Oh, thanks, Don, and thanks, Thomas, for the invitation to speak. Yeah, it's an emerging topic, so thank you for listening in. So first of all, I'd like to say, obviously, I'm an adult CF physician. So we're based in Wales, which is a couple of hours west of London. And what you can see there on our red dots are where our patients are scattered all across a large geography of Wales. And on the right-hand side there, you can see this is where we work in our CF centre. So we are very fortunate to have a dedicated building, and the top floor you can see there is where our MDT, we all are hosted up there. The middle floor is our ward, which is a 16-bedded ward for cystic fibrosis. And on the ground floor is where we hold our clinics, and those front windows are where we actually have our gym for patients to use as inpatients, and our team run outpatient sessions within those gyms as well. So I was giving a talk to colleagues a few years ago about perceptions of cystic fibrosis, and you can probably tell that picture of our team on Laser Quest was taken quite a few years ago. And this is what we were like as adult CF physicians, what we were doing. So you can see bottom left there, we had full wards of relatively young people having recurrent courses of IVs, and you can see on the X-ray there an impression of severe cystic lung disease. Lots of medications, broad range of airways clearance, supplements, really time-consuming treatments for people living with CF. You can see we had lots of sputum, lots of chest physio, and lots of people going towards type 2 respiratory failure and needing transplant. So you'd think with those patients that I've just described, what are their risks for cardiovascular disease? So we know that there is CFTR present within the heart, within the endothelium. So if you've got CFTR dysfunction, you'll have increased cardiovascular risk. We know that our patients had high levels of inflammation. That itself is a risk factor for cardiovascular disease, as is hypoxemia. We know that historically these patients were more inactive than the general population. We know that they had a different diet to the general population with high salt, high fat intake. There are some medications that we use that could increase your cardiovascular risk in CF. We know that a proportion of our people have chronic renal disease, again, another risk factor. And up to 40 to 50% of our adults have CF-related diabetes, again, a further cardiovascular risk. There is evidence of sleep-disordered breathing in CF, and that being itself a risk for cardiovascular disease. And obviously, we have a proportion of people who have had solid organ transplants, be that liver, kidneys, or lungs, and that, again, is an independent predictor of cardiovascular risk. So, you'd expect that we'd see lots of cardiovascular disease historically, and maybe we need to just calm down. Although there are lots of risk factors, our people that we cared for with cystic fibrosis were protected by a few things. So they'd had long-term fat malabsorption and lower LDL cholesterol levels than the general population. They were often of normal weight or low BMI. Actually, the prevalence of smoking in CF was less than the general population. The prevalence of hypertension less, and less non-CF related diabetes than the general population. And I think maybe the key message was if we rolled back 10 years, maybe the median survival was in the 30s and possibly below the age where we'd expect cardiovascular events to be happening. But as we all know, the landscape of CF has changed. Now, this is one of our patients who's actually had a couple of stents put in for following a heart attack, and we're seeing a new area, and we're starting to see cardiovascular events. So strokes and heart attacks are being seen in adult CF services all across the world. So this is some work from Freddie Frost and the guys in Liverpool who looked at TriTech databases and CF registry databases and looked at what the actual relative ratio of people having major adverse cardiac events were. And you can see that the risk ratio for CF is high. It's high for myocardial infarction, higher than the general population just for heart failure and for atrial fibrillation. And we did a little bit of work in our own population here in our adult CF service using the QRisk3, which is an online tool that you can use to predict people's risk of cardiovascular disease. And within it, you can also calculate what your healthy heart age score is. So this is valid for people over the age of 25. And what it will do is when you put in these factors that it asks for in the calculator, it will give you your equivalent age of what somebody in the healthy population or non-CF population, if you like, what their risk would be. And what you can see is all the red dots are above that control line with blue. And so the median we found was that people had a heart age 80 years older than their biological age in cystic fibrosis, suggesting that there is an increased cardiovascular risk in this group. So I think we can see that there probably is a cardiovascular storm coming. And then when we think about the sort of patients, and I mentioned this chap earlier, what our burden of work in adult services has changed. And you can see when we asked him to write down his conditions, cystic fibrosis only comes halfway down the page. And you can start to see some of the risk factors that he might have. So his BMI is elevated, he's already got hypertension, he's talked about having diabetes, his cholesterol is up, and he hasn't actually, and he's got sleep apnea, and he also hasn't mentioned the fact that he's had cardiac events. So maybe we need to think about unlearning some of the things that we've held true, and are some of these factors that have traditionally protected people with cystic fibrosis, are they changing? So I'll run through a few of those. So I mentioned that perhaps we weren't expecting people to live long enough now. And on the top, you can see there what's happened to the UK CF population, and you can see the shift towards the right as people are aging. The population is aging. And then the bottom left, you can see there, that's from the UK CF registry median survival. So now if you're born in the UK today with cystic fibrosis, the median predicted survival is up over 64 now. And the same is replicated from the US registry data that you can see there. And we know that when we're reaching these sort of ages, 40% of deaths are actually caused by cardiovascular disease and its complications. And there's some nice work using the Canadian registry data from Anne Stevenson and Bradley Quan, and they backed up what Freddie Frost and Liverpool have said. And you can see there that pre-transplant cardiovascular disease is occurring much more frequently than the general population, perhaps 3 times more in cystic fibrosis. And interestingly, in the second table midway down there, you can see that the age that people are starting to get this is also younger than the general population. So that there for cardiovascular disease for CF is actually 33 they've put in. I mentioned the other risk factors that we thought people are protected about. Actually, I mentioned CF, adults with CF, when we're going up in the age range, around 40% will actually have CF-related diabetes. We've historically thought that people don't have hypertension. With our new modulator drugs, we're seeing an increase in blood pressure with the new modulators in adults. And you can see some work there from CHEST 2023 that almost a fifth have actually got elevated blood pressure. And I mentioned that people historically have been quite protected with cystic fibrosis about their cholesterol, but now we're finding increases in total cholesterol and LDL with improved absorption with our new modulator. So this is becoming a new problem in adult CF centres. And then another big problem that we're seeing is the change in body mass index now on people who are on modulators. And you can see the top bar in each section of the age ranges is what the population were in 2018, and then roll on 5 years later. You can see that there's a huge increase in the proportion of people who have a BMI of 25 to 29.9, which would be overweight classification, and a BMI of over 30, which would be classified as obese. And then on the bottom, when we're getting to 50 plus years of age, you can see that we're starting to go up towards the general population in the UK, with over 50% being overweight or obese now. And this is some work from Dave Proud, who's our lead dietitian in our service, who looked at people's body composition before and after going on to the modulators. And what you can see is that he's found that people's fat-free mass has improved, people's BMI has increased, but interestingly, normal weight obesity has actually increased massively. And we know that normal weight obesity is itself a predictor of cardiovascular disease, and it's particularly prevalent in women with CF on the modulators. So I hope we can show that actually we are needing to do a bit of rethinking, because people, our population we care for now, are at risk. They're living longer, and some of those things that have historically protected them from having cardiovascular events have now been removed. But we know from the American Heart Association that with optimal primary prevention, cardiovascular disease is largely preventable. So that will be our challenge in this population. So when you look at who are nice when they talk about exercise, there is evidence that exercise can reduce your chance of cardiovascular disease in the general population. And this is what has been put out as what we'd be expecting adults and older adults to be doing activity-wise. I guess then the question is, how do we know what's good for people living with cystic fibrosis? So looking at a bit of the literature on exercise and cardiovascular risk factors in CF, there has been publications. There's some evidence coming out that you can see there that there can be, with exercise, there can be a positive impact on insulin secretion, body composition, exercise capacity, can change people's glucose tolerance and improve it. Can, again, looking at the 2018 paper, you can improve anthropometric measures and some improvements in lipid and glucose. There's some reports of improving people as regards to CRP, TNF-alpha, adiponectin and leptin. So there is some evidence emerging. They're all relatively small numbers. And there's been, obviously, this really useful from Thomas, this Cochrane database review. So pulling all of this together, we know that physical activity interventions can improve exercise capacity, less effect on quality of life, lung function. Importantly, we know that adverse effects of exercise are rare, but there's definitely a need for new evidence, especially in this new era that we're now in with the highly effective modulators. And the picture there is of Rachel, who was leading our cardiopulmonary exercise, and she set up cardiopulmonary exercise testing in our service and made a huge difference. And she is busy doing a first into research PhD, trying to gauge more information and evidence about what we need to do going forward exercise-wise in this community, and how can we modulate their cardiovascular risk with exercise. So then where we sit today, then, if we look at the European standards of care for people with cystic fibrosis that's come out in the last year or so, when you look at what's there for exercise, there is a recommendation about regular standardized exercise testing should help to guide us and advise us. And then when you look at the UK CF registry, there is a section on there to what exercise test has been performed. And then when we look at the UK CF registry report on exercise testing, this was from 2023 on what exercise tests have been done and which exercise test has been done. And what you can see is actually there's relatively few. So there, if I was looking there at there's been 10% of adults and children in the UK have had some form of exercise test put into the registry. And you can see the breakdown of what they are. They're a mixture of CPET, shuttle, step tests, 6-minute walks, and other. So I would say there's probably a little bit more thinking to be done about exercise testing in clinical care, and possibly some thinking that we could maybe do as a group of what would be important as well to be putting into registries to collect. And then going back to the standards of care document, they said CF team should support people with cystic fibrosis to be physically active and to exercise regularly. And they acknowledge very sensibly that most effective type, duration, intensity of exercise for people with CF, we're still not quite sure. But obviously the onus is on the CF team to review exercise capacity, consider it at each clinic, and really importantly, to try and individualize and offer choice. And then I just put a couple of quick thoughts in the red box of it's important to take it in context that 2/3 of people with CF who are over 16 are working or studying. And we know from other chronic long-term conditions that people spend less than 1% in the time of their healthcare professional team. So people are managing these conditions largely on their own. And then, of course, there's a lot of interest about people with CF using exercise as their primary airways clearance. So even aside from looking at cardiovascular, people are looking at exercise to replace physiotherapy. And obviously Don and Zoe have done lots of work with this. And it's a new area that they've recorded in the registry, looking at what are people doing purely for airways clearance? What's their primary way of doing that? So obviously what we're doing about cardiovascular work has got to also overlap with what people are doing chest clearance. And then I just put some people that we look after in our clinic along the bottom, just to show the range of people that are having their care at CF services. So you can see the bottom left is somebody who's not been on a modulator, who's got really severe and has got type 2 respiratory failure and would be awaiting a transplant. And next to him, many people in the group may know, is Josh, who's an elite athlete. So our guys in clinic are trying to balance these different needs of what people need from our service. In the middle is some artwork with one of our patients, just showing there's lots of issues with body image, there's lots of issues with adherence, there's lots of issues about not wanting to be seen, exercising in a gym potentially, and how we start to change that mindset. One along is somebody who's also had significant cardiovascular events, but is really in that sandwich generation of the going to renal dialysis 3 times a week, going to appointments, looking after elderly parents, and looking after a child with a disability as well. So they're really people trying to fit in lots of different things. The next guy with the virtual reality headset on did make our exercise technicians laugh, in that they said that they'd been busy doing lots of exercise, but it was literally sat down, participating on an online swimming, but watching other people do it. But there's a lot of really trying to work out what people feel they are doing, how accurate is that, and how much is the actual intensity of what people are doing. And then our bottom right picture is a picture there of Sophie, who, as we speak, is trying to be the first person with CF to row the Atlantic. So she's just gone past the Canaries. So she is en route as we speak. The message of this is there's such a range of people that we are, as CF teams, trying to cater for. So there was this really nice paper, again, Don and Thomas have done about rethinking this and looking that obviously there are short-term benefits for both physiological and psychological for exercise. And that just, again, reiterating that point of trying to get that structured exercise program for people and tailored within their lifestyle and what they can achieve is difficult, but it is going to take this MDT approach. And so the pictures on the right-hand side are just to show we are trying to move away from this really paternalistic Victorian model of patients being passive and in a bed and waiting for the healthcare team to tell them what needs to happen. And this is very much with the no healthcare 2 or 4 people, but actually with people. And then our team, we try and use this Formula 1 analogy with our person with CF is the driver, and we're trying to keep them on a track, and they'll come into pit stops in our clinic trying to make every contact count. And I may well be, let's say, the front wing adjuster as the doctor. There are lots of important people in that team putting on different bits on to keep that person on track to their goal. And exercise, I think, is going to be a really key part of this going forward for all the things we've talked about, not just the airways clearance, but to modify cardiovascular risk. And then I'll just leave with just a couple of summaries. Obviously, we've talked about the landscape changing. We've talked about cardiovascular storm coming for CF, because all of those things that may have historically protected people, I think, are fading away, which is a great thing, but we need to be aware of that as teams. I think there's going to be a huge role for gathering more data, and within that, we need the research to help guide us. But I think there's also opportunities to improve what we're collecting registry-wise to help try and inform. And obviously, there's the existence of biobanks to help try and increase that speed of translational research. I think this obviously comes with service demands. So I mentioned, for example, Rachel has set up our CPET testing. It is a huge drain, an additional thing that the team need to provide to people with CF. And obviously where CF is being commissioned, that really needs to be taken into consideration. Perhaps the new role that some of our teams, particularly our physiotherapy and dietetic teams, are now facing in cystic fibrosis. But it does align very well with here in the UK, our NHS 10-year plan, which is very much about going from a sickness role to a prevention role, very much going away from a purely hospital role to a community role, and going away from analog to a real digital, and exploring the possibilities of digital. And I would just again highlight just the value of person-centered care and the huge role it's going to have in being adaptable in what we try and offer the CF population. And I'll leave it there, but very happy to do any questions.